So the agenda today, I'll just briefly cover it. We'll just maybe go through some introductions or reintroductions. POCUS, just cover what's currently going on with POCUS Snapshot in 2022. We'll discuss the Rural POCUS survey, which wrapped up in December. Now we have some data that we'll be able to present to this group. And then this is the last funded working group meeting we have for our budget. So understanding, kind of where we are now, I guess we really need to get a sense of what the future of the working group is, and this work in general. So just to reacquaint us, I think we have some new faces. So introductions, if we could. So I'll start and then pass to folks that are here. So I'm Tracy Morton, and I'm a rural physician from Haida Gwaii, the land and waters of the Haida Nation. And I work with Virginia and Tracy DeLu on RCC BC's POCUS strategy and other programs to do with POCUS. And I'm looking forward to this discussion to know how the working group can continue to inform the work that Virginia and I are doing. Oh, so maybe I'll just pass on and I'll stop sharing. Maybe I can pass on to Tracy DeLu.
Perfect. Thanks, Tracy. So great to see everyone. I'm Tracy DeLu, and I'm calling from the Silk Nation here closest to Penticton Indian Band in the Okanagan. And I work on a number of really great projects with RCCBC, and I also sit on the Interior Health Research Department team. But specific to this, I support Dr. Tracy Morton and Dr. Virginia Robinson in the pursuit of all things POCUS, as well as work with a number of you that are on this call in different projects and endeavors too. How many different ways can I say as well or two in this sentence? I am so excited to be here today. And I think I covered everything, and I will pass to Virginia.
Okay, nice to see everybody. I think I know everybody on the call, and it is great to see you all on the same screen. I am calling from the Ktunaxa Tobacco Plains Nation in Fernie, BC. And as previously mentioned, I'm co-working with Tracy Morton on this rural POCUS project, and really all things POCUS, POCUS through the RTVS, POCUS with John on the ECHO project, POCUS with Jude on the evaluation. Any way we can do better, and what's the next move? It's a fast moving group, and that's always exciting. But good to take pause and say, okay, what are the next steps here? And I will pass to Svetlana.
Thanks, Virginia. I'm Svetlana. I'm a fourth-year medical student. For those of you who don't know me, I'm calling from the Comox First Nations territory at this time, but I've done most of my training through Kelowna. I have been involved with Tracy, Virginia, and Jason on the rural POCUS project for the past couple of months. So I'm here today to talk about our data analysis. I will pass to Jason.
Hi, everyone. Jason Kern. I am sitting here in Penticton Regional Hospital on the traditional ancestral lands of the Silk Okanagan people. Happy to be a part of this call. I kind of sort of parachute into POCUS related meetings and try to add something useful each time so hopefully I'm really banking on contributing something useful this time around as well. So I work on rural health research for Interior Health and physician engagement, and with direct ties to the Rural Coordination Center of BC. I'll pass to Jude.
Great, thanks, Jason. I'm Jude Cornelson. I think I know many of you. I'm an associate professor in the Department of Family Practice. I'm not clinical, I'm research. And to that end, have spent the last 20 years or so looking at ways to support and sustain rural health services through rigorous evidence and evaluation. And our team has just completed phase 1 of the RCCBC point of care ultrasound evaluation. So we'll be talking about that in a bit. And we're embarking on a very ambitious phase 2 where we're trying to measure quality, do some quality markers in BC. I think right beside me is Kevin.
Sorry, hi. Kevin McNeil. I am clinical professor at the Department of Emergency Medicine, and I'm based kind of mostly out of my truck, I think. But I work in the Sea to Sky corridor in Whistler and on Vancouver Island in Nanaimo. And I guess my connection to this group is I'm also the director of the rural, a 3-month fellowship in rural emergency. One of the pillars of being POCUS training for physicians who work in non-urban centers in British Columbia, with our goal of taking people from knowing nothing to leaving after 3 months, having had some experience teaching, so that they could take that back to their rural communities.
Perfect. And Kevin is on the phone, so he is not able to
Oh, yeah.
see us.
Yeah, I can't see who to send to. Yeah.
No worries. Let's pass it to the other Kevin.
Hi, everybody. Also on the phone. My name is Kevin Fairburn. I live, work, and play in the Ktunaxa region, Kootenay, Nelson, British Columbia. I work primarily with the House program. And I want to thank Tracy, and Virginia for all the hard work with this group. It's been an amazing project, and it's been really, really helpful for us. So we run a course primarily for rural practitioners, and we're just really excited how we can learn from what everybody's doing here to better serve our rural practitioners with ultrasound education moving forward. And I think we'll speak to a little bit what we're doing later on. And I'll pass to Antigone here. Antigone, thank you.
Thank you, Kevin. Hi, everyone. I'm Antigone. I see some familiar faces, but also some new faces. So excited to hear from you guys and get better acquainted with what's going on the provincial landscape of POCUS. I am calling in from the Musqueam, Squamish, and Tsleil-Waututh territory, also Vancouver. And I work for UBC CPD on the House program. So I have a lot more of the kind of like administrative background on that program. And I will pass it to Oran.
Hi, everybody. I'm calling in from the Musqueam, Squamish, and Tsleil-Waututh people. I'm in Vancouver. I think most of you I know. I'm good to see everybody again. I'm an emergency physician in Vancouver here, general POCUS advocate. I trained Kevin back in when I was running the fellowship days and still involved in a lot of academic projects. And then really, I consider myself an ally of the rural care. I'm like a wannabe rural doc, hoping to kind of spread point of care ultrasound where it's most useful and most relevant. And always excited to work with a group that springs to action. So it's always been a pleasure. Who's left here? I don't know. I can scroll through. How about John?
Thanks, Oren. Afternoon, everybody. John Polovich here, calling from the Stolo Nation here at Central Fraser Valley, and great to be part of this group. I guess I'm here with a few different hats on. Number one, my REAP support as we support POCUS education in the province for rural docs and the House program in particular for residents and so forth. And then we're doing some work with the Virtual Echo program, which many of you on the call here are partnering in, which is great. And we'll give an update on that as well. And help support the RTVS program, which also has, through RCCBC, it has great relevance to POCUS support. And I can pass it over to Pete.
Hi, everyone. Pete Tonseth, calling from Rendezvous Island, the ancestral home of the Klaus people. I am a radiologist and nuclear medicine physician who works in Vancouver and Victoria remotely from Rendezvous Island. And I am the clinical lead for ultrasound in the undergraduate program at UBC. So very appreciative of this group and all the input that you guys provide, because it really helps to bolster the undergraduate push to get more POCUS involved. And I will pass on to Rohit.
Good morning, everyone, or afternoon. My name is Rohit Singla. I am an MD PhD student at the University of British Columbia, working very much at the intersection of ultrasound physics, point of care ultrasound, image analysis, and so on, as well as working with Pete on a few educational initiatives. Happy to be here. I am not sure who's gone next, so maybe perhaps someone can help me pick someone.
Vin.
Thanks, Virginia. My name is Sin. I'm a third-year resident in emergency medicine at the Vancouver General Hospital. I'm calling from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. Currently, I'm working on some ultrasound projects with both the group of medical students in Prince George as well as the medical students in Vancouver. And I also work on educational content with the Canadian Point of Care Ultrasound Society. I will pass it on to Lester.
Hey, good morning, everyone. Hadi, Claytley Tene Snatchathia noticed me and January Karasta Tara Klusuzi Nakasli Sehazia, Daka Sehazia. Just wanted to acknowledge the traditional territory of the Claytley Tene people, work and play in Prince George, and we'll eventually do some work out here. But main role is with RCCBC when talking about the calls to action. So thank you, Tracy, for allowing us to be here. And of note, this program's been really helpful. We had a POCUS device that we brought out to going out with Kersey County, and we had a person that fell off a ladder for 20 feet. And it was just nice to get, a quick fast scan and then transfer the patient to Prince George. The emerge doc really appreciated that. So these great events of having these and providing the training and skills and all these supports have been really helpful. So thank you for all the work that you guys do. And basically the thing that we're here for is just to advocate for more point of care in rural and Indigenous communities that may not have these kind of services. So to really up titrate and train the clinicians who do this outreach kind of work. And the next person is, let me see here if I can find someone here. I think
we're done with that. I think you were the last one. Yeah. Save the best for last.
I don't know what.
Thanks, everybody. I'll just go back to share screen. All right. Everybody can see that? Yes? Yes? All right, great. So thank you. So we'll just do a quick rundown. Some of these programs are new and might not be familiar to everybody. So I think maybe if we can just get a bit of an overview of the different things going on. First, we piloted this Rural POCUS Rounds project. It's a virtual POCUS education, mostly didactic, but with lots and lots of cases. It was initially just piloted for 4 sessions over the course of the summer, funded by initially RCCBC in partnership with UBC CPD, and it was quite popular, and it got more popular as the pilot went through, and the evaluation was quite solid. So we've now done 8 sessions total. We did another 3 in the fall, and we just did another one in January. And they're accredited. There's a scientific planning committee. They're free and they're virtual. And it turns out that we've got a pretty large audience, a wider audience. I think we had somebody from Great Britain. We've got across the country. We've had a few people like from Newfoundland. I think we had some folks. I think there was an Australian as well, I think, if I remember correctly. It was very exciting to see it's not just a BC-based educational initiative. It seems to have some legs. Not sure if that's really acceptable as far as UBC goes, but I don't care. I think it's great to just have interest in this pilot. And I think we're getting between sort of 30 to 50 participants every session. So power to Zoom for that. This is the landing page on the UBC CPD website. And we're now recording the sessions. We didn't record any of the pilot sessions, but we're now recording and archiving for later retrieval by anybody that's interested in it. So you can certainly see kind of the nature of the content, about an hour long on Fridays. This is just some, screen clips from a couple of the different sessions that we've had. We've got Virginia's, ocular ultrasound, and there's a DVT one in the lower right, and Kevin Fairbairn's SBO talk that he did. So that's, any questions about the Rural POCUS rounds? No. Might be asking folks at this table if they're interested in running a session in the future. We're diversifying our instructor base. So we're going to be having a 5th year internal medicine resident do the one in February later this month. And Dr. Dan Kim, emergency doc, is going to be doing the one in March. So you're all, of course, welcome to attend. So next up is so based on the real-time virtual supports that RCC has in place. This is, I think, an expansion of that service. So I'll just maybe pass over to Virginia, who's really leading this really fantastic weekly POCUS support.
Yeah, thanks, Tracy. So this was a bit of a spin-off combined from the supercluster in POCUS project, where we were really trying to support people who had received an ultrasound probe but didn't have much training, and we could only do it through Zoom. And then in addition, in my role as a Mabel and a Rudy doctor, there was also some interest there in helping people teach how to do virtual ultrasound, like teach ultrasound virtually, should I say. So we started off on Tuesdays, and the idea was I was just going to have like office hours, and you could call in and say, I have trouble with this exam, or I have trouble with that exam. But what it's turned into is really a teaching session where I have a model every week. I do live scanning. I take requests, although that kind of turned into like me doing Cirque du Soleil with an ultrasound. It was really complicated. So, because I'd be like, oh, let's do some lung, and let's do this, let's do that. So now we have themes. So I just did lung ultrasound and dyspnea protocol a couple of days ago. And next week, I think we're going back to cardiac. Anyway, variable interest, anywhere from like 5 to 25 people. Always looking, some of you on the call have kind of zoomed in, and I'm always looking for feedback, because for me, it's an hour of talking into the ether. I have no idea, other than people don't leave the session, you know, how to improve this session or whether I'm even achieving my goals. So always looking for feedback. And if you would like to, Kevin Fairbairn's going to do a session maybe on small bowel obstruction in the coming weeks. If you'd like to volunteer for that as well, anyone is welcome.
Thank you. No, I haven't attended that many because Tuesday's usually a call day for me, so I'm quite busy. But they're fantastic, and I admire you for live scanning, because the tech alone to share screens and have a model is pretty substantial. So kudos to you for doing it. I think it's fantastic.
Yeah, I have become a little more technologically savvy. I now have 3 cameras running per session. So
wow.
Yeah, it's interesting.
So we'll carry on with you, Virginia, for the InPOCUS project, which has been a phenomenal. It's actually why I kind of reached out to RCCBC, is because it's quite incredible what the scope of nature of this project is. So maybe we'll just carry on with Jude and Virginia to explain where we're at with InPOCUS now, and what kind of evaluation we have in place for what this project has done.
Yeah, if you want to jump in, Jude, we're so happy that Jude was able to take this on, that had the capacity to do the evaluation for the InPOCUS supercluster. And it's kind of midway. We've finished phase 1 and we're about to go into phase 2. And so Jude's going to give us a little rundown of the phase 1.
Sure, thank you so much. And this is excruciating for me, not only because I like to talk a lot and I don't have much time, but mostly because we have so much rich data from the interviews we did that is really thematic, illuminating, and gives clear direction, I think, of where POCUS needs to go next in British Columbia. So I've been working with Virginia and Orrin on the evaluation. We've just finished phase 1. I am calling in from the traditional territory of the Tsawat Coast Salish Nation, also known as Salt Spring Island, where I've been absolutely delighted to live and work for the past 22 years. What we've done with regards to the evaluation is started with phase 1 by looking at the experience of people who received the probes from RCCBC. So we're looking at motivation, kind of value of the probe and barriers, and we did 22 interviews between February and September last year. I'm going to go through what we found quite quickly so we can maybe just spend a few minutes on the recommendations that came out of it. But just to say we did, I don't expect anyone to look at this, just kind of the mapping, mind map we did for the themes that came up out of the interviews. And, you know, probably this quote really encapsulates so well what we heard, you know, again and again. I'll just let you read it.
Would it be possible for you to read it out loud for those of us on the phone?
Oh, I am so sorry. Of course. I forgot. Of course. I just have to move my thing out of the way. Okay. POCUS is an incredibly important tool that I don't think I can practice in rural Canada without any longer, because it allows me to verify a diagnosis. If I've strongly suspected it, it allows me to generate new differential diagnoses, and it allows me to do it rapidly at the bedside without having to wait. I'm diagnosing things I never would have otherwise picked up on. It vastly increases my confidence in the decision to either keep patients in the community or send them out. I thought that really captured, you know, the gist of what just about all the participants in the evaluation was saying. But I'm just going to move on here because we put it in the context of Everett Rogers' theory of diffusion of innovation, which I'm sure most of you have heard about. It's just an explanatory framework to understand how an idea or a process spreads through a population over time, with the end result being the adoption of a new practice. And there's 5 categories. And again, I'm sure you've heard about the innovators, early adopters, early majority, late majority, and laggards. After doing the interviews, at least with the cohort that I talked to, I think rural POCUS is just on the verge of early adoption in BC. There's still a lot of energy coming from the innovators, but it's moving out a little bit further. So digging a little bit deeper into Rogers, he's got suggests 5 elements of an innovation of a new technology that will determine the speed of adoption. And we framed what we heard from participants around these 5 elements. I'm not going to go into it in depth, but I'll pull out some take-home messages because it was really nice. It wasn't a difficult fit. It just seemed really intuitive that what people were saying fit into these categories. So in terms of relative advantage, the thing I'd pull out here that I think is really important is better decision-making, leading to reduced transfers and increased job satisfaction. I'm being a bit strategic here because the increased or reduced transfers is something that, of course, funders really want to hear about because it saves the healthcare system money. The other thing that I really focused in on and heard a lot about was the increased job satisfaction. And heavens, anything we can do to increase rural providers' job satisfaction is super, super important. So that ties really nicely into, and I can't go into depth, but into a little bit more understanding of recruitment and retention and using it as an incentive for some communities. Compatibility is about the notion of how compatible POCUS is with, you know, existing practice, and all participants in the study said that the use of point-of-care ultrasound was an extension of their generalist medical training and experience, and several of them articulated that their use of POCUS was basically an extension of the physical exam, or as one person said, extending the senses of the practitioner. And the sense of compatibility is, I think, going to be foundational to widespread usage because it's low barrier to start using, right? And I went too fast. Complexity. So almost all the participants that I talked to in the study noted that the use of POCUS was not terribly technologically complex, but there was an interesting sense of social complexity around the practice setting. So, you know, the technological complexity was easily addressed with additional exposure to technology. The practice setting and the interprofessional kind of discussions and relationships are not as easy to put my finger on in 2 minutes and to nail down, but it came up amongst several participants. The notion of trialability is all about figuring out what works and being able to do course corrections that are needed to optimize the use, in this instance, of point of care ultrasound. There was some really interesting discussion here around the influence of payment models on POCUS and the role of billing codes for POCUS scans that I can't get into. It's just a teaser, really. And observability is all about what is evident that you can see that shows the value of what you're doing. So what folks in this study told us a lot was increased patient and provider satisfaction. So lots and lots of really, really nice narratives about the impact of the point of care ultrasound on the patient in a rural community and how positive that was. So that's pretty cool. I'm going to go right into the recommendations, but I always have a propensity to start with values propositions underscoring. So basically, what's motivating or what's almost assumed under the recommendations. And the first one, and I do not need to tell this group, but I'm amazed how often I have to remind people that rural is different than urban, not just the low volume and the geographic isolation, but a whole bunch of availability and resources that are not available in urban settings. And it's really important that when we talk to people outside of rural practice contexts that we point that out and how important additional supports are in rural communities. So also the need to respond to IHI's quadruple aim. So we're talking about provider satisfaction, we're talking about patient satisfaction, we're talking about self-containing costs as well as we move forward. And we've got some proxy measures actually about cost containment, which I think is going to be really important. The last one is the notion of providers wanting or needing to work to full scope of practice and how point of care ultrasound actually enables that. And that's what we want for efficiency across the healthcare system. So those are kind of the assumptions going into the actual recommendations, and I'll go through these super quick. I know I'm almost out of time, starting with system level recommendations. And these are mainly, these are mainly about support for access to POCUS technology and education. The need for a quality assurance framework came out. I tend to prefer CQI, quality improvement, but people talked a lot about quality assurance, so they knew that they were scanning correctly and they were seeing what was needed to be seen, and the prioritization of or desire for real-time case review. By the way, I know that the InPOCUS program is doing a lot of these things, and even when people were telling me about these things, I had to bite my tongue to say, this is actually happening already. So it's, again, the slow diffusion, getting people alerted to the fact that some of this stuff is already happening. The other system level recommendation is that the data that we have is pretty convincing, and we're, again, just starting on the quality data right now, but the experiential data is pretty convincing, enough to say, in combination with the international literature, that we should probably focus on a provincial strategy, which I know is what this group is doing for a rapid diffusion of POCUS, because we'll get maximal benefit and increased optimal patient outcomes, I think. So the specific program level recommendations for the POCUS program itself was more support for skills development and skills maintenance. Many participants commented on information sessions, refresher courses, or personal consultations that are already happening as part of the InPOCUS program and how beneficial they were. They also noted the limitations to online learning. And of course, I did this evaluation in I don't know if it's the middle, but right in COVID times, and people couldn't get together face to face. So there was quite a few comments about how it would be great to practice in person. And there was also a bit of concern expressed about the inherent low volume of scans across a lot of rural BC and deciding how they were going to maintain skills afterwards. So lots of interest in having support for dedicated POCUS mentors. participants pointed out a couple of things about why this would be really important, and also signaled out some people on this call, i.e. Virginia, who was providing that mentorship and doing a really, really good job of it, how they just wanted more to be able to call people up and have a POCUS mentor. One thing that came out actually that kind of fits in here that I thought was really interesting was several comments on the notion that when training sessions occur, healthy models are used. And a lot of people said, we want real live what we see in our ED. That would be much more helpful, which is, of course, a challenge. So the other thing, kind of related, was a clear desire for a community of practice, and it was very clearly articulated. You know, in addition to knowledge exchange and technical skills, participants really pointed out their thoughts on the benefit of a community of practice and supporting use and integration of POCUS into their clinical practice. Several participants, for example, expressed technical and workflow challenges that could be addressed by more experienced users, and just the desire for a rural cohort where they could talk to other rural practitioners about some of the challenges they were experiencing. And lastly, the support for ongoing evaluation and CQI. And, you know, I'm just going to be totally transparent. Definitely people mentioned this. I've really put it in as a recommendation, because I believe any health services innovation must be encased in a rigorous CQI framework, so we can course correct, we can you know, work peer to peer and with super users. I think that this is a super important part of it, and lots of enthusiasm about learning from other colleagues who have maybe more experience. So, very quickly, next steps, as was alluded to, we're just starting an investigation. We're looking at quality scans, and we're doing this through a pre-post scan survey that I'm working on with a Skookum grad student of mine who's very, very determined and keen. It's really ambitious, and we recognize that, and I have a little bit of trepidation because we're going to be asking a lot of a couple of hopefully very keen providers to take a few minutes before and after scans to fill out a hopefully straightforward survey, and also upload images to the database, the provincial data bank, so we can do a quality measure afterwards with specialists, and they can see what they saw and what their diagnosis would be. And we're starting the pilot phase of that right now, just testing it out, making sure everything works, and we're hoping to launch beginning of March. So I'm happy to answer any questions. I know I went over, but thank you. This has just been the coolest thing, to talk to people across the province and see how incredibly enthusiastic people are about this, and actually, what I always like to see as an evaluator, what a difference it's making in practice.
Oh, wonderful. The Rohit had a question. Actually, Rohit, would you mind just asking the question?
Yeah, but it looks like Dr. Robertson directly asked. I will ask a related question. How might the latent workforce of sonographers help us achieve these goals? Because these are pretty big goals, and we've got the expertise pretty much, let's say, next door. How can we leverage them?
Yeah, that is an excellent question. And some of the people I talked to in some of the communities actually referred to stenographers locally who they would go to for advice if they could. A lot of people that participated in the interviews didn't have local access to ultrasound, which made the use of point of care ultrasound even more important. I don't see any reason why we could not have that supportive interdisciplinary community of practice of people who want to support rural folks who are learning to use point of care ultrasound involved. And it would be wonderful if we could figure out how that would work, if compensation is needed, what the structure of that would be. But that's an excellent point, and it did come up. Thank you.
Thank you.
Fantastic. Thank you. Yeah, and I think that's one of the keys to addressing some of the teaching manpower issues. I mean, whether you're at the faculty level, faculty of medicine undergrad level, or at the residency level, we hear it. Most of the conversations are, we just don't have instructors. We don't have access to instructors. And particularly in BC, where there's a distributed medical school model, some sites like Prince George is fantastic. They've got they've got a couple of super dedicated instructors that take all the med students, whereas Kelowna and Victoria, there's much less access. So there's an equity issue around exposure for med students. So yeah, the sonographers are fantastic teachers, and we have to think of some model to bring them in. All right, I'll just go back to the share screen. Thanks a lot for that. All right, so we'll carry on. So speaking of undergraduate medical education, it's the next section here. So Pete knows us intimately. Dan, Kim, Virginia, and I had a discussion with the UBC Curriculum Committee sometime, I think, late springs in the summer, and it didn't go very well. There isn't sort of the sense that this is kind of universally important to all medical students. And so that's why we're at this present state we are with fairly limited access to ultrasound during the medical education experience. But don't fret, we did manage to work through and come up with an elective. So it's a POCUS dedicated elective, and there's going to be 2 streams, urban and rural. So the urban stream is going to be situated at Vancouver General Hospital and Royal Columbian with the Internal Medicine POCUS Fellowship. So they've got their cadre of instructors, and they're probably going to take up to 3 to 4 students in that urban stream. The rural stream will be piloting a single 4-week elective, likely in September this year, with the idea that we'll hopefully sort of demonstrate kind of how it all works. We're hoping that the objectives will lead to the students coming through and developing basically a portfolio of images and clips along with the clinical data, so that they get certain applications covered in this elective, with the idea as well that they'll have a presentation to the local medical staff at the completion of their time here. So yeah, that's very exciting that UBC is supporting the POCUS elective for senior students in the undergraduate program. So I'm going to move on to Sin, who's intimately acquainted with peer-to-peer teaching. So you'll just pass over to Dr. Liu, Sin Liu.
Hi, thanks, Tracy. You can just all call me Sin. So I'll tell you a bit about what I've been doing with UBC medical students. So there's kind of 2 parts to it. There's the Vancouver group and the PG group, which are kind of parallel to things that I'm doing. I think the PG group has just a bit more ahead, so I'll tell you what's been happening with them. Dr. Ivana Senchuk and Dr. Christina Boucher are also members of this working group, but they're not here today. And I think it was through this working group that they heard about what I did with the medical students and the curriculum at McGill. So they reached out to me and said, hey, can you help us with our Prince George medical students? Because they've been involved with them. And I would say that everything that exists there currently and that is sustained is thanks to their work. It is not my work, because they're the people who are on the ground and who are like really local champions there. But I met with them as well as the medical students of that ultrasound club that they have. And there's 6 medical students who are involved, 3 second years and 3 third years. And they were clearly very engaged, very motivated. So I made them the offer of giving them a 1-day instructor training for their club members, so that then they can move towards teaching their own sessions instead of always just being the facilitators that organize the sessions for like staff and residents to teach medical students. So we did that on October 30th. And I went to Prince George for like about a 30-hour period. And we had a 1-day kind of boot camp where in the morning we did just kind of fundamentals. So the scans that we're teaching are just kind of 4 core scans, lungs, including pleurofusion and pneumothorax, subxiphoid view of the heart, through fluid, and AAA. We decided to leave actually IUP and like pelvic scanning for like a different time, just because it's just more involved. So that was for the morning. And what they did in the afternoon is that I ran an instructor workshop for them, that's kind of the expertise that I bring to their group. And if people have questions, I can tell them more about how that specific part works. But essentially we did an instructor workshop. And then the plan was that for the subsequent sessions of the year, where the ultrasound club, so these kind of core members would host sessions for the medical students, that they would be the ones teaching. And the people supervising them and supporting them would be either myself from like online from a distance, or would be Dr. Christina Boucher and Dr. Ina Sanchak, who are already in person there. It just lined up that I was actually in Prince George in November, December, because I was doing rotation at the hospital there. So I was able to be part of their session that they delivered to kind of the general medical student population there. And just so that everybody's aware, there are 30 medical students per year in Prince George. So overall, there's just over 100 medical students here. So it's still like a fairly significant population. And we hosted a scanning session for subjective view of the heart on December 13. And the students that I taught, so the kind of 6 core members, or I think 5 of them who attended, were the one actually teaching those medical students. And it went really well. And they were able to teach that content. And then we had a bit of time left at the end, so we added some advanced cardiac scanning too. But in terms of the basic scan of subjective view of the heart, they were absolutely able to teach it. And then I came back to Vancouver, and my colleagues, Irene and Christina, continued to work there. And on January 19, we hosted another session, which was female pelvis and IUP, and also the students were teaching. And for more sessions of the year, we're going to do in February, mid-February, February 16 the plan is gallbladder and male pelvis, and also the students will be taught those scans ahead of time, and they will be the one teaching. In addition to this, students were they were really motivated. Like I said, I kind of really invested in this group because I thought they were really engaged and had a lot of potential. They will be hosting weekly kind of drop-in scanning sessions with the medical students there in Prince George. So what they're establishing is on Sundays at 10:30 a.m., they're doing kind of an hour and a half drop-in sessions where students can just come and practice, and they are the ones there that are facilitating and teaching those sessions. So I'm kind of really happy with how things went in Prince George. I don't know how sustainable weekly sessions are going to be. I think maybe it's going to be bi-weekly, whatever amount meets the needs of the medical students there. I think this is complementary to the core curriculum that they have, but it offers just more scanning time and a bit of support, because I'm thinking about what I wanted as a medical student when I was training is just more time with my hand on the probe and maybe somebody to guide me. So that's for the Prince George group. So we have a bit of a near-peer program going. And my kind of continuing my involvement with them probably will be a training session maybe once or twice a year. And now we have a really good working relationship, and I'm really happy to kind of sometimes just go there and help out. For the Vancouver group, we, part of the photos that Tracy showed, there was one kind of symposium day that he was there teaching, I was there teaching, there were a few other faculty and residents teaching as well. What I'm hoping to do with them, and we're kind of looking at dates currently, is to reproduce that model where you have a one-day training session for the medical students who are more interested, more engaged, more involved, and then they can be the one delivering more sessions to medical students in the future, to the general medical students. Challenges that I'm facing is that it's somebody needs to do that follow-up, right? I'm saying in Prince George, who is doing that follow-up and who's the local champion and taking on that work of supporting them in becoming instructors is Irene and Christina. And they are very dedicated, and they've been doing that for a long time, even before I was involved with those medical students. And then in Vancouver, I think we also need people to support those students and to support them if we're going to be building a near-peer program. So currently what I'm looking at is trying to find allies, colleagues, friends to help me do that, because I'm also aware that it's honestly not something I can take on by myself, especially because the Vancouver group is a bit bigger, will be probably offering more sessions and things like that. So it's still all in the works, and part of why I'm in this working group is to feel inspired by all the work that you're doing, and also kind of find ways to build connections and see who is interested and can contribute. If you have any questions, let me know.
Yeah, I have a question. How are you funding your travel and accommodations? We're not funding it, so is this out of pocket?
It is honestly just out of pocket, and I kind of write it off as part of I earn some money for ultrasound here and there, so I just put it as part of expenses that I do for ultrasound work. But we've talked about whether there's funding for this from this working group, and there isn't. It was important enough to me that I just kind of went. And the students there hosted me, which is really, really nice. So that's helpful. But truly, yeah, there's definitely a funding issue. And for me, nowadays is trying to balance my time, my studies, my involvement in ultrasound and all that, which definitely is complicated by like financial factors.
Yeah, and a lot of the faculty support for the ultrasound student clubs is volunteer. I mean, Irina Sainchuk has been doing this for kind of years, every, I think, Mondays or on a regular basis, pretty much as a volunteer. So yes, I don't know how to solve that. We're supporting the education of medical students in a way that's really under-recognized and certainly under-supported as far as payment goes. But thanks so much. I'll just go back to the presentation. Any other questions for Sin?
Yeah, I have a question, Sin, and we can take it offline for sure. I was interested in how you structure your instructor session and whether like you provide resources for them to refer to. I know Irina, Christina, I guess, and yourself are EDI-based and probably have access to those resources. I don't know if you want to make a few quick comments or.
Yeah, so there's actually two parts of it, right? There's a part where you learn ultrasound and then the other part where you learn how to teach ultrasound. And the part where you learn ultrasound, what we do kind of tell them to look at are the resources that the Canadian Point of Care Ultrasound Society offers, which people can access for like $25, which I think like just overall, like we said, like I said, like if anybody can pay, I'll just pay for you. Like that it's not a big deal. It's just that this is like high quality resource and that we will be teaching you based on this. And it's important that we all speak the same language. So like I speak the same language and Irina and Christina will speak the same language, which really contributes to learning. So that's kind of the resources that we use. And then when I teach kind of that morning portion, which is the simple part, which is just teaching ultrasound, that's where we're basing ourselves on. And then that is kind of the building blocks for that afternoon part, or if, ever, sometimes I do like a weekend long thing, the second day is the instructor training part. So you already have the language, you have all the same steps that everybody's teaching so that you have a framework to use. And then how we structure that instructor's kind of training session is I give a very like short, like 20-30 minute didactic part where like it's about like learning theory and things like that. And then I like tell people what language I want them to use, what probe movements, directions and things like that, which are more simple, and like also the framework of like external landmark, internal landmark, area of interest, troubleshooting. And then the core part of that is the practice of actually vocalizing the instruction for like a basic scan, like subdiaphragm view of the heart, for example. So what we do is I put them in groups of 3, and then you have a medical student, usually who's the model, a medical student who is the role playing the learner, and then the medical student who is being the instructor, and they're essentially being themselves. So person role playing the learner will be just scanning and kind of pretending they don't know how to scan. And the other person who's teaching has to bring this presumably like first year or second year medical student who's never touched a probe to being able to do that subdiaphragm view of the heart scan. And that room, the supervision that we provide as like the instructor of the instructors, or we do it one-on-one. So I'm watching this person teach and my interactions are with this apprentice instructor. So when I see that they're struggling or I have feedback for them, like I am coaching them about how to teach. And then in a different room, because we have 3 rooms running at the same time, like Irina's doing this in the other room or Christina's doing this in the other room. And then we swap the roles, and then somebody else will be teaching, and the teaching, we're doing the same thing again. Like you are vocalizing, like you are teaching the subdiaphragm view of the heart. So every student that we're training goes through this process. And then that takes a certain amount of time. Usually it takes like about 45 minutes to an hour for like one scan, and then we move to the next one. And let's say we're doing lungs or we're doing free fluid in the abdomen. And then that's their fundamentals that we're building for teaching, but that is still not enough. And that next time that they do it, we will still be there in the background and like helping out or like, giving tips, but they're the one teaching those medical students who are going to this session that they've organized. So that's kind of how like the ball rolls, and hopefully they can, with both like the learning and the teaching, they increase their own expertise and their own kind of motivation, but also like just competence, and then they can keep doing that and teach more other medical students. And the goal of this is that eventually these students who will be trained can teach other medical students how to teach, and then you get the ball rolling in like a way that is self-sustainable.
Yeah, fantastic work. Thank you for sharing that instruction on how to instruct instructors to teach. Thank you.
Yeah,
we can
thanks,
talk about
Sim.
this more offline too if you want. This is like a very brief, like quick way to say it.
Great, thanks, Sin. And yeah, the left-hand image is at the Vancouver campus Medical Student Alumni Center. And on the right was Prince George. So moving on to something heart-related. So this is the teleechocardiography project organized. I think John and Rob Moss are the leads. So over to you, John.
Yeah, thanks so much. Yeah, great. I was just going to share my screen. Yeah, so this is a project I'll share with everyone here. I don't know if people have seen this, but this is a short 2-pager we have that kind of tells the story of this virtual echo project that's kind of gaining legs and moving forward in a really very positive way. And many people on the call here, Tracy and Todd, Virginia, Oren, have all been contributors to it. And we have some research and evaluation support through the RCCBC, which is noteworthy, and the Department of Family Practice. So James Liu, Rob Moss, and myself started this idea, it's well over a year ago, probably a year and a half ago. It takes time for these things to kind of start to take shape. But in short, for people who haven't heard about it, this has many crossovers to the great work that's already been articulated, and just hats off to you all for what you've been doing and the sharing today. Wow, it's really humbling. This project is really around echocardiography, and to start with the most remote communities and community providers in the province. So it has a strong equity lens. And if you think about the inequities in accessing formal echocardiography in the province, so if you live in Dease Lake, if you live in Fort Nelson, if you live in Tackle Landing, you have to go to heroic lengths to often putting yourself or your family or others in harm's way to get an echo study at a formal echo center in the province. And many people just go without, and that's the story of remote communities. So this project is looking at working with rural providers in remote communities. And we've actually gone through developing a list through an equity lens, and people on the call here were helpful in that bit of work, identifying which communities are the furthest away from formal echo centers, not necessarily by distance, but understanding that 100 kilometers of logging road is different than 100 kilometers of asphalt, and 100 kilometers of open water is very different than 100 kilometers of highway. So there's a few things that need to be considered in that, but where we want to start the journey. And so the idea is to bring down a cohort of rural healthcare providers, working with Rob Moss, who, I don't know if you know him, Dr. Moss. He's a echo specialist at St. Paul's, and so he's kind of our expert, if you will. And Virginia and James and others have been incredibly helpful in building this out. We have contributions from UBC, their digital team, in their med IT team, really in helping support the IT bit. But we want to upskill these docs, develop a study protocol, which the docs will learn about, including the scans themselves, the hands-on part, as well as the study protocol, and then take that information and those skills and knowledge back to their rural communities, the remote communities, and then they will scan patients, which will then we will use the technology that's already been pioneered, thankfully, in the InProcus project, which is a great synergy for this project. the Change Healthcare platform that we've learned about, that can be the cloud-based PACS system, if you will, to allow the scans to be uploaded onto this system, whereby Dr. Moss can retrieve them, interpret them, actually generate a report that will then go back to the remote community and the provider. And the idea is to understand that, I mean, to really dumb this down, this truncated echo study, because it's not a formal echo study, will that be a benefit for the patient and the provider in managing certain conditions? We think it will be, and so it's pretty exciting. So the potential here is that we could actually influence the paradigm of which echocardiography is accessed for remote communities, and so there's a lot at play here. Again, there's a lot of overlap with other work that people have talked about. The paradigm shift of changing how echo might be accessed and whether we can actually glean enough useful information in a report that will positively influence patient care. Understanding there's a whole bunch that comes between a patient in a remote site and a formal echo center. So I'll stop there. Let's see here. There we are. There's the second page of the project, and Todd Alex kindly joined us, and from the RISE group, and Todd will probably be one of the benefactors of learning here moving forward, as some of you on the call maybe. So pretty exciting stuff. It's all starting to take shape, and we'll report back at the next meeting, which I assume there will be a next meeting of this group. Thanks, Tracy. Happy to answer questions.
Tracy, I have a question for John at some point.
Yeah, go for it.
Yeah, John, that sounds quite exciting. You probably already thought of this already, but one of the things consider, if you haven't, is when you're evaluating the usefulness or the benefit of that program, is like a lot of what we did in the early days of ultrasound is to try and be meticulous about people not generating false negatives. Like false positives aren't as bad because they usually go on to a study, but it's sort of, that's what we were trying to be meticulous about. And the benefit about teaching, people are having a rigorous framework to make sure they don't have false negatives, is that all those people are in such isolated areas. But that's also a huge benefit, because if you get someone who gets a normal negative, then particularly in a rural community or a remote community, you save all the angst and cost and harassment that they have to get through to get as you described, to go get all that effort to get the study done, and then it's normal. That's the ones that really, I think that's from a rural perspective or a remote perspective, could be a huge selling point and an advantage point if all you get with the physicians is, or your practitioners is, hey, we've proven that these people are normal, so they don't actually need to go get the study. I think that's almost as big a benefit or bigger than actually identifying the pathology that you could send then for another study. But you probably already consider that as part of your endpoints.
Thanks, Kevin. Yeah, excellent points. And we've talked about that, as well as the kind of opposite, whereby a provider will pick up a macro problem, so severe aortic stenosis or something, and then that triggers an urgent formal echo and expedites the care that a patient needs, so they don't sit in a queue for 14 months. So there's the negative, and then there's the severe stuff. Then there's the stuff that, well, certainly in our practice, Todd and I, how many of our post-MI patients get 3-month follow-up echoes? I'm involved with a provincial heart failure group right now, and echo is being part of the kind of gold standard of workup is unachievable for many patients. So can we get an EF that will then provide the proper management of heart failure patients, which are many in this province. So there's lots to consider, and so it's going to be exciting for sure. So thanks, Kevin, for that. The other part I should note is that because Rob is interpreting the images, the rural provider is really just obtaining the images, and so there's not much on the interpretation side other than generating the images to be uploaded to be interpreted by the echo specialist. So it can be a little bit different than just general POCUS.
Amazing. So what I see here is we go from point of care ultrasound to point of care radiology. We're bringing both technology, the technologist side of things, and the radiologist to the bedside. I mean, maybe not in real time, but functionally, it's at that level. So amazing, like conceptual leap here.
Tracy, and Kevin and people who started this journey, but when POCUS first started back in the day, I remember running a Eddie course in Fraser Lake back in around 2005, and we had the grade 12 students come from the high school and get credits for being the models and things like that. But the pushback came from radiology and from the specialists that what are you guys doing out there? And so that's changed somewhat, but bringing the specialist into the solution here, I think, is also transformative, where you have an echo specialist, at the ivory tower who's now supporting rural to make this, see if we can make this work.
Yeah, I called Rob about a case, an inpatient, very severe heart failure lady, and we had to make a decision about whether to send her. And we were able to just do exactly what you did with basically an iPad and Rob Moss helping us get the scans, and he gave us a firm diagnosis, and she did really well with his advice. So it was really remarkable.
So that's what we just have to standardize, Tracy.
Yeah. Okay. Well, thanks a lot for that.
Let's hear about this.
Go ahead, Kevin.
I said, just don't let Pete Townsend hear about this.
Very funny.
Oh, is he on the call?
All right. So we'll move on to POCUS fellowships, and there's a few in BC. First, we've got the UBC Internal Medicine POCUS Fellowship. That's Shane Arishinkoff and Katie Wiskar, both on the working group. They provided, so they're expanding their service. They can accept 2 fellows per year. They're always either 4th or 5th year internal medicine residents, and they have them for a full 6 months. So they come very skilled with a lot of internal medicine applications under their belt. Along with that is Dan Kim, who's, I think he's the medical lead for the UBC Emergency Medicine Fellowship, which is situated across many of the large hospitals in Lower Mainland. And I think they have 1 to 2 per year as well. They're looking at expanding a hospitalist service, so branching out beyond the internal medicine realm and training the hospitalists. And I think that's happening at VGH. And they are having funding issues as well. So that's their update from Dan and Katie. Did want to, of course, mention NEEP and NOEEP. We've got Kevin McNeil on the call here from Nanaimo. I think before we got going, I was just asking Kevin to provide a bit of an update on kind of where things are sitting for NEEP. So Kevin, did you feel like you wanted to share anything more about NEEP, where it's at now?
Yeah, okay. I guess for those of you that don't know it, it's a 3-month sort of emergency fellowship funded through the JSC, through the RCCBC, that we've been running for, I think, about 5.5 years now. We run 2 cohorts a year, and the pillars of it are offering opportunities for a full-time 3-month fellowship for non-urban based practicing physicians in BC to to train in clinical emergency procedural service and point of care ultrasound with an academic program thrown on top of that, a bit like sort of a mini residency. And we've had 2 grants thus far, and our second grant is running out this spring. So we're in the process of applying for an extension, possibly on a more permanent footing basis. We expanded about 1.5 years ago to Prince George, and there's part of the proposal was to expand into the interior and possibly another site at Vancouver Coastal. I guess from a point of care ultrasound point of view, that concept of the program is to be able to take people who have no skills and to give them an introductory course. We do a workshop in conjunction with all the emergency residents in the 3rd year enhanced program every fall with our rural fellows from both Prince George and Nanaimo. That involves an intro course and then scanning to take them to sort of independent practitioner status over a course of 5 days. So it's about a 5-day intensive boot camp. Then our fellows will get some advanced scanning sessions throughout the rest of the 3 months, and it culminates with them teaching an introductory course as an apprentice instructor before they leave. The idea was to provide them with some resources to become sort of a local resource to the communities that they were returning to. And I think this spring we're accepting our I think we've trained in total with Prince George 40 already. To that
Thanks,
level.
Yeah, we've had NEEP grads come through Haida Gwaii as locums, and they're truly you can see the big difference. They're just ready to go, much more adept with things, and they're grabbing the probe all the time. So it's great to see. Any questions for Kevin? All right, thanks a lot. On to House, the flagship course for BC, hands-on ultrasound education. And so maybe over to Kevin and Antigone. Nicole Didiak is unfortunately not able to join us today.
Hi, everybody. I'll be brief here on this one. First off, just a huge thank you, all the amazing work that's been done. So many questions and comments on my end for each project. I'm just super excited, but I'll spare everybody my enthusiasm for now and just focus on my task. So we're a rurally based program, of course, that just runs for a couple of days typically. One of the big things that we've recognized is that we all love courses, we all love doing them, we all love participating in them, but that's not necessarily the best way to cement these foundational skills. So one of the things that I'm excited about moving forward that we're looking into is partnering with the coaching and mentoring program at UBC CPD and really establishing some mentors and some longitudinal courses. Our first sort of pilot coming up with our OB program, longitudinal course with Duncan. Part of that's going to be virtual as well. So that's sort of what we have immediately on deck. A couple other things that we're looking at. Restarting our IM program. We have been in discussion with the VGH hospitalist as well, although we're running into a number of barriers in regards to getting that off the ground. I think our focus immediately, and I'll let Antigone speak to this, is just catching up on the backlog from the pandemic and really getting used to in-person courses again. But so we have a busy spring, and we're looking forward to doing what we can. I'll pass over to Antigone to fill in the rest. Thanks.
Thank you, Kevin. Yeah, lots of exciting development work happening for the House program. I can give you guys a bit more of a logistical update on House and the demand for courses and interest and what's coming up. So we went back to doing in-person courses in May of 2021, and we had a very successful kind of half course year that we wrapped in November. We're entirely booked up for 2022. We have 10 community courses happening, 3 courses for rural residents in Vancouver, and then a House OB and a House EM course happening at the Rural Health Conference in Penticton. So lots going on, and we still have quite a significant wait list. We have about 40 individuals who are interested in registering for courses as individuals, not as communities, and then close to about 25 communities that are hoping to get courses on the calendar in 2023 and beyond. So demand is high, and the feedback that we've gotten, I mean, has been really, really positive. But yeah, lots still to do.
Thank you. And I am just going to share a stat here. This was sent by Nicole about 6 months ago. So this is about May. And there's been 1,066 participants in 89 courses since its inception. So that's a lot of practitioners that have gone through the program. So I have no idea how BC compares in terms of rural uptake and use compared to other settings, but I think it's higher. I mean, we have no data for that, but it's a pretty phenomenal course.
I do want to, I'll just jump in. I want to pass out a big thank you to Tandy Wilkinson, who kind of set the program up, and also recognize we're not the only program out there. But one of the things that excites me is that if we're sort of replaced in a sense, if with all the work that's been doing, if the medical students are coming out trained, I mean, that's fantastic. So really love what's happening in this group and all the contributions that everybody has. Thanks, Tracy.
Wonderful.
Tracy?
Yeah.
Just John here, just a note on House and REAP, the Rural Education Action Plan. So the stat there with residents, REAP helps support well over 90 residents per year for the House. And the only part that's noteworthy with this group is we are in constant discussions with UBC to positively influence them to take ownership of ultrasound training for family practice residents and arguably all residents of all different stripes. So that work's continuing. I'm hopeful, not overly hopeful, that will come to fruition probably in the next year or two. But until that does, REAP will continue to support the residents in obtaining their exposure to the House, which is so valuable. So just an update for the group.
Yeah, thanks for that, John. We're very excited about our February course, and that's one of the big things we're focusing on just with the nature of the pandemic is getting caught up for all the residents to make sure that they have that skill that's going to serve them incredibly well. As we all know, in those first few months of practice, it's a difficult place to be, but when ultrasound can be your friend, it's a lot more reassuring that way.
Thanks, John. So last, and then we'll move on to another section here. Just to kind of finish off, Virginia and I, and hopefully Tracy DeLu, and I know John Palovich and several other RCC team members are going to be heading out in April to Ottawa to attend the Rural and Remote Medicine course. So we'll be doing a couple of talks on both office space and more just in general rural Canadian use of ultrasound talks, and then 3 workshops. So hopefully it'd be great to see all of you there. It'd be wonderful to meet some people in person, because I haven't even met Virginia in person just yet. So and we'll move on to the survey. So as mentioned earlier, we've had a phenomenal medical student, Svetlana Hadikin, who's helped us with our data crunching. This survey went out to over 1,000 rural practitioners, and I won't say too much more. It went through ethics, and those are the partnering organizations there in the lower right that helped out. And here's the folks that have contributed to the survey, and hopefully will contribute to next steps with manuscript writing and so on. So I'll just pass over to Svetlana, and I'll just stop sharing here.
Thanks, Tracy. I'll just share my screen. Okay. So I have been involved for the past few months, I mentioned at the beginning of the call, with the Rural POCUS project. They have graciously let me jump in halfway through the project and assist with the data analysis. So that was really great to join the team. Our team, and I missed one of the docs in there, but mostly I've been working with Tracy and Jason and Dr. Morton, Dr. Robinson. Doctors Kim and Elsinski are going to be helping with the manuscript writing phase, so they'll be involved as well. So the survey itself, I'm sure most of you had heard about it at some point. It was in order to assess the use of POCUS in the rural communities in BC, mostly trying to understand the attitudes and barriers about using POCUS. And it's quite a unique survey, as most of the research in the field so far has been urban-based, so focusing specifically on the rural communities was quite unique. As far as research questions go, it was to assess what types of providers are using POCUS, how often and for what clinical problems, how does their degree of rurality affect their attitudes about use of POCUS, what system level barriers to using POCUS were present, and the highest priorities for POCUS education, as well as the most useful ways of supporting clinician use while they're practicing. So the demographics, people who responded to the survey, we had contacted just over 1,000 physicians through CME, and then another 150 or so through other means of contact. 271 people responded to the survey as per Qualtrics. 225 of those were family practitioners. There was a handful of nurse practitioners, medical residents, and 13 specialists. We did leave the specialist data out of this presentation just for ease of presentation, but it was very consistent with the family practitioner data in terms of the perceived barriers, the use of POCUS, kind of consistent across the board. So as far as the age breakdown, most of our respondents, you can see, were sort of in the 30 to 50 range, which makes sense given who's likely practicing and who's in education and who's retiring and whatnot. The people were mostly coming from Canadian medical schools, but we also had a handful of international medical graduates. About a quarter were international. And as far as practicing health authorities, we were getting people from mostly Interior Health and Northern Health. We did get a handful from Vancouver Coastal and a handful from Island Health. We'd considered why we might be accessing more from Interior Health and Northern Health, and it could be given the spread of rural communities. It could also just be that our POCUS champions were Dr. Morton and Dr. Robinson, who are located in Northern Health and Interior Health. As well, there was, as far as who responded, there was variable certifications. So mostly people responding were CCFP, but we were getting some CCFP EM, some residents, NPs, like I mentioned, and there was even a midwife who responded to the survey. So rurality of survey responders, you can see that most of the responders had been in practice in a rural setting for more than 2 years, and majority actually being more than 10 years. So we were getting very rural responders to this survey. The size of the community that they primarily work in is usually 20,000 or less. So just about 80% of the respondents work in communities with 20,000 or less people in their catchment area. And Indigenous patients in their practice. So it was really impressive to see the number of Indigenous communities that were being reached by this survey. You can see here in the boxed off area, that's about 40% of the respondents have an Indigenous practice that's greater than 10% of their practice population. So regarding this content of the survey itself, we've addressed a few different topics. So access to ultrasound and training, the usage of POCUS, and then the barriers to using POCUS. So regarding access to ultrasound and training, this was whether or not people had access to a diagnostic imaging department in their community. So 71% said that they did, but 29% don't have access to a diagnostic imaging department. So of those 29%, their distance from the nearest diagnostic ultrasound was quite high for the most part. So you can see the majority of people really over 50 kilometers, a huge proportion, 100 to 250 kilometers from the nearest ultrasound. And again, as mentioned earlier, somebody pointed out that Travel times are different depending on if it's a logging road, if it's over water. So absolute kilometers may not necessarily be indicative of time. So when asked how long it actually takes to get to the nearest ultrasound, very few people saying that it's less than an hour. Most people somewhere above 2 hours, up into 5 to 10 hours, even for some of these communities. So whether or not they'd ever had accredited POCUS training or education, most of our respondents had not, had accredited. That was 75% of them had. And of those no's, 75% said that they do plan on taking additional training. The yeses, they used different courses. So there had been people who had practiced or had gotten training during residency, ultrasound fellowships, house program was mentioned, EDE, EDTU, and other online modules. So a variety of different ways of receiving POCUS training. 63% of the survey responders said that they use web-based POCUS resources. So that seems to be probably likely due to the fact that we're getting a lot of isolated communities and it's challenging for people to access things. So online resources became really important, I think, especially during COVID. Exposure to POCUS in medical school and in residency. So you can see here that the majority of our responders had zero exposure to diagnostic and procedural POCUS education in medical school. So 63% had no diagnostic training, and 66% or 67 and 66% had no exposure to procedural POCUS training. So it's pretty indicative that we have not done a very good job of training people in medical school the use of POCUS up to this point. And residency was similar. It was a little bit better. Only 42% had had no exposure to diagnostic POCUS, only 43% to procedural uses of POCUS, but still very few hours of training throughout residency. So whether or not they had access to a POCUS machine in their community, 88% said that yes, that they do. And those 88% say that they mostly use cart-based. Some people have handheld. I think a lot of the time it's cost of whether or not they actually own their own handheld. And then some people have access to both, which is really great. Regarding the usage of POCUS in their communities, so 84% say that they do use POCUS, and we actually did survey a handful of people. 16% said no, they don't use POCUS. So it's nice to see that we got some of the, a handful of people who aren't POCUS champions to see what their barriers to using POCUS might be as well. Of that 84%, how often are they using POCUS? And you can see that the majority of them are using it at least once per shift, which is really excellent. So it's, I know that there's often talk about whether or not there's enough material, whether or not they have enough patients to practice on, but they are using it at least once per shift. So there must be something. How often are they documenting their findings? I was actually really happy to see that most of them are saying they're documenting all the time. So they're finding things that are valuable enough to put in their charting and say that they've done POCUS on the patient. A quick note about reasons for storing data, because there was some comments about why they would choose to store data. And a lot of people were saying that it's documentation for patient charting, sharing with specialist colleagues, or quality assurance purposes. That speaks to a couple of the other projects that people mentioned earlier today. Settings for POCUS use. So that's mostly in the emergency room or inpatient medicine, but we are getting some use in the ambulatory setting as well. So in their clinics or outpatient departments, a little less so with pre-hospital environments or home visits, but a handful of people using those as well. And then as far as how often they're performing POCUS, you can see that when it's, how often it's providing information that changes their clinical management. So this was really impressive to see, is that majority of the responders were getting information that changed their clinical management over 25% of the time. And a handful up here 50 to 75% of the time was 24% of those responders were saying that they're changing their management 50 to 75% of the time secondary to their POCUS usage. And just a quick note about whether or not they would find artificial intelligence tools valuable in the setting. Left ventricular ejection fraction was deemed to be useful, but there was a handful of other things that were questioned, particularly in the obstetrics and gynecology realm. And it seems that people would generally find AI tools as valuable when they're using POCUS. And then we did ask a handful of questions about their comfort using POCUS diagnostically and procedurally. People are finding that mostly they're comfortable using it for FAST exams, AAAs, EFAST exams, and a little less so with cardiac views, DVTs, MSK assessments. And then in terms of procedural use of POCUS, they were finding that it was quite good with abscess drainage, pleurocentesis, paracentesis, central lines, and had a harder time with things like lumbar punctures, nerve blocks, pacemaker insertions. So some of those more I'd say rarely used skills, things that they don't often do. And then we did ask those same questions about where POCUS is deemed to be valuable, which we could create a whole additional presentation about that data. So if anyone has any questions, Tracy, or Virginia, I'm sure would love to speak to it at the end or at another time. So barriers to POCUS usage, this was our third category, and we asked people what the reasons were for not performing POCUS. And you could see a lot of responses around lack of training, which goes back to at the beginning where we mentioned that majority of our responders had zero exposure in medical school or residency. Not enough time to perform, which I think can link back to lack of training as well. If they feel that they're not experienced in using it, they may need more time to perform an exam. Lack of quality assurance and review of images, again, speaks to their comfort. Availability of courses and cost of courses, so people not recognizing what resources are available to them. And then we did get some quotes from this other category. Lack of experience, hard to find time to get more, cost of machines, lack of confidence, infrequent patients to low volume, difficulty attending courses, not certified, POCUS came along late in their career, lack of a decent machine, and need to be organized to save images and review with colleagues. So those comments from the other category really do fit back into those other questions, but some of those quotes were nice to see as well. And then we did have a question that related specifically to billing, and it was very variable in responses. So you can see here that when asked if billing is important and people's interest in using POCUS, some people saying it's not important at all, some people saying it's very important. So it's quite variable as to whether or not people find billing is important to kind of encourage them to use POCUS. Willingness to take more training, whether or not billing would be important, again, very variable. And willingness to acquire POCUS credential, also very variable. So billing doesn't seem to be the most important factor in people's use of POCUS. Does apply to some people, but not necessarily to all of the people who have barriers to using POCUS. So when asked how they could be better supported to use POCUS, we have some physician quotes here. So some people saying that there's lots of courses and there's lots of money. They don't even know how to know which one to choose. There's, again, funding to travel. POCUS refresher courses would be helpful. Forums or discussion groups, so ways that they can have, sounds like POCUS mentorship, discuss with their colleagues on the types of bread and butter cases that they're seeing. Hospital support for maintaining equipment, so I guess POCUS machines just being old, run down, not well maintained, not serviced. High quality machines, again, that's the same sort of thing. So regarding next steps, Rural Docs have a lot of funds for our CME, and there's lots of courses that can be brought to people. So I think a lot of it would be focusing in on advertising and knowledge translation to these people so that they have more knowledge around what resources are available to them. And then I think Tracy, Virginia, even Jason, if anybody wants to jump in and what the next steps are. I know that the next steps are partially manuscript writing, which I hope to be involved with. But as far as after that, I'm not sure what comes next.
Well, thank you. That's what we're going to spend the rest of our time talking about, actually. So very nice segue. It's almost like we planned that. Any questions for Svetlana?
Tracy, Kevin McNeil, I have a question for her about that survey.
Yeah, go for it.
Hey, thanks. That was a lot of information, and I was trying to just get it all sort of orally because I couldn't see your slides. But with regards to the people around barriers to use and those 16% of people that don't use it, I wasn't clear. Was your survey just sort of in general? You were asking everybody what their use was, and out of everybody that you asked, 16% said they didn't use it. And if so, did you split off what those 16% thought were the barriers to use?
So we didn't split it off. Yeah, oh yeah. So we didn't split it off when we were doing the full analysis. Qualtrics does have an option to break it off if we wanted to see specifically what those 16% were speaking to. We asked all physicians who had responded what their barriers were, because even the ones who are using it seem to have barriers to using it. So there's avenues that we can go down in terms of recognizing what the biggest barriers are for everyone or what the barriers are for people who aren't using it at all. But specifically for this presentation, it was all of the responders.
Right. Okay. Yeah. I'm just sort of thinking out loud that looking at the barriers, seeing if there's a difference between the barriers of people who aren't using it versus the people who are using it, that might lead to what are the sort of highest impact barriers that are preventing the people who aren't, really keen about using it, what those are. And I guess, and the other piece would be around the barrier or around the billing question. I don't know if you had the information. Can you break that down between, say, people who are hospital-based versus office-based? Because it would seem the office-based or physicians in private practice or the way that they're funded might be looking for ways to offset the cost of purchasing equipment. More so than the people who actually don't have to worry so much about purchasing equipment.
Great question, Kevin. This is Tracy. I'll just jump in here. It is definitely possible for us to look at that based on responses to one of the previous questions and where are they using that. So we could take that as a determining factor in looking at the billing info. So I have written that down, as well as the first comment around looking at the 16% of non-users and barriers. Of course, this is just a first analysis that Svetlana did of the overall findings. So as we get into the manuscript writing and further into the project, we will be looking at those different parts. So thank you so much. And I have recorded both of those, Kevin.
Okay, thanks.
I'm seeing a great conversation between Jude and Jason in the chat about parallels between Jude's work and this survey.
Yeah, I was just thinking all the way through. I mean, it would be, I guess, Tracy Morton, we're going to be talking about this now, but where you're seeing the biggest impact of your results from your survey, what your objective is with the survey, and who your strategic partners are in getting this information to, because that would help a discussion about how we could use the two data sets to strategic advantage. There's lots of overlap. I think the qualitative interviewing went into a little bit more depth in some areas, of course, because we're doing an interview modality, which gives a little bit more descriptive richness, I guess. But I guess, Tracy, is that what we're going to be talking about now?
I mean, I think the research out of InPocus, really rich qualitative interview-based data and more survey, broader survey of practitioners, they align very well. And like you said, there's overlap. So right now it's just like, let's figure out what the story is around the data. It is consistent a lot with what the literature is already saying. However, what's really unique about this, one of the data points is just, if you look at like urban settings, particularly urban EDs, they'll typically quote a rate of around 25 to 30% sort of clinically meaningful use of POCUS. In other words, this is changing my management in some way, whereas this is more like a mean of about 60 to 70%. And perhaps it's because the settings in which you're doing it are rural, and the time it takes to get access a full diagnostic scan is huge. So you're maybe more likely to devote more time to it, for example, as one potential interpretation of that. So it could be that the best use case for POCUS is in rural settings, more so than any other setting. It may be critical care. You could make the case that it's more useful, but I guess what the data shows, we still have to kind of come up with sort of a story and kind of a themes that we're behind you with the InPOCUS work. I guess what I'm trying to say, and how to align our messages. I think we need to spend some time doing that. And I think that's where we'll create some real synergies with who to broadcast this information to.
Yeah, and how to do it strategically for sure. By the way, Svetlana, great presentation. Super, super interesting. Thank you.
Hey, just to follow up
can I chime in quickly? Go ahead, Kevin.
Kevin McNeil or Kevin Fairburn?
Kevin McNeil.
Oh yeah, just to follow up on that last comment, I think most of us that use it realize that rurally and where there's a long delay to transport and definitive imaging and all that sort of stuff is where it has the biggest impact. So I was thinking strategically, like UBC is, and my apologies to anybody who's on the call from UBC, but we know they're going to be late to come to the table. But one of the, it's been proven already, but one of the strategic maybe things is to try and focus on the programs that are delivering more rural focused education is maybe where it could start, because that would be a smaller ask. And then doing all medical students, and then it might generate enough groundswell that you get further push into broadening it. But I think with the data that you've generated, both qualitatively and survey-wise, as well as sort of anecdotally, that we might get more bang for our effort buck by trying to convince some of the people who are driving formal education if we aim for starting in the places that are rurally focused.
Well, I think there's a reason why RCCBC is sponsoring this work, because I think it's a much easier conversation to have. And certainly, there's a lot of funding through the JSC that sponsors the RCCBC itself. So I think you're talking to the converted, and NEEP exists, I think, and is funded through the rural lens. So I'm glad you're on board. If I think about the highest yield ways of, and just knowing the future, like this is not going away, and it's only ballooning. You look at the literature and the number of publications, and it's just explosive how and some medical schools have adopted POCUS lock, stock, and barrel right from entry. Like you get your ophthalmoscope and you get your POCUS, your handheld POCUS, on entry to medical school. Funding's another story, but we're in an early adopter phase provincially, and I think why not think about having every medical student learn right from year one forward, and push for that, right? So yes, I think focus on rural, but think broadly that kind of everybody as a medical school graduate should have, I hope, a basic level of use.
That's awesome. I wanted to just chime in. You were trying to talk about I don't want to call it the spin, but how to organize the data and interpret it with thematic high level. Like I think you can correlate really easily how in the urban settings, users have probably the highest proficiency in like a density format. Like emergency doctors, for instance, is part of their core curriculum now to get ultrasound training. It's built in a more rigorous fashion than the GPs who are really covering most of rural BC. And then you correlate that with like such a lower utility rate versus like you're trying to penetrate all this education into like really high use. That's clearly where the need is, and where it's being delivered is maybe not very effective, even where it's at.
Yeah, I mean, some ideas could be that we have a rural POCUS fellowship. You know, that really take this on, that we're gonna, you know, maybe expand NEEP and have a stream that's just, you know, maybe 6 months of a rural POCUS fellowship. I mean, that's just thinking blue sky, but something along those lines.
Well, yeah, I mean, you know, like from the Department of Emergency Medicine, for instance, and UBC, like if you really kind of step back and, you know, where does the training effort need to be? It doesn't need to be on training more emergency physicians to be experts when it's not really penetrating into their practice, you know.
Well, thanks so much, Svetlana. That was wonderful. Just pull my screen back up here once again. So that leads us to the last phase here, which is what the future of this group is. Maybe I'll just, before we get into that, but hopefully have a bit of a roundtable. You know, so I think the short term is that we'll be working on the completing the analysis for the survey and kind of getting that out there and sharing that, not just in a manuscript form, but also we don't have to wait to have a publication to get it disseminated and get decision makers, this information in front of decision makers. There is an overall kind of idea to create an implementation strategy for POCUS, you know, informed by the survey and informed by the working group. So, you know, at some point later this year, hopefully we'll have a bit of a document, a bit like the Rural Emergency Needs Assessment that Tandy Wilkinson did back in 2015, 2016, because it led to a whole series of innovations that we're currently benefiting from now, including House. House came from that. So I see there being a rural POCUS strategy kind of come of this, and maybe be like a capstone kind of document that could guide further work in all of our areas. I can't see myself continuing indefinitely in the same role. I do want to see some sort of wrap up for this sort of phase of my involvement at some point in the next year or two. But I just wonder if we can maybe open it up to just deciding, like, what's the utility of the working group for your work? Do you find this useful? Do you find your participation meaningful, et cetera? And, you know, thinking ahead to this next fiscal year, 2022, 2023, we'll have to build in the role of the working group. So maybe I'll just pause there and just maybe open this up to the participants.
I think it's really great to get all the brains in one room, even if it's not that frequent, you know, just to hear what people are doing and kind of really leverage, because there's so much of this whole project that is everyone kind of leveraging what everyone else is doing. And I feel like if this momentum falls off, then it drops back to word of mouth and kind of trying to find out what other people are doing. And it's not as synergistic as everyone kind of connecting efforts.
So it sounds to me like it's a thumbs up for the working group continuing.
Oh, yeah,
okay.
I give both.
And then Virginia. Well, what any other comments or discussion?
Yeah, Kevin Fairburn on the line here, just chiming in. It doesn't necessarily have to continue in the same capacity. I know Tracy, Virginia, and RCTB, you guys have put in tons and tons of work. But echoing what Oran said, I mean, for me, coming from the House perspective, what you guys have put together here, it's imperative for our coordination. And I know this is something that Tandy really envisioned as well, is this community, right? And what we're able to do is just connect everything, and everything's going to work so much better together. From the House program, I can direct people towards the TeleEcho program. Yeah, I think it's going to be really, really helpful just to see how we can help each other. So if there's a way for it to continue forward so we can keep connected, like Oren said, I don't want to lose that and have us go back to this word of mouth where things start falling in the cracks and we start duplicating our educational efforts. Again, because I'm from an educational standpoint, I'd just love to see us work together on an ongoing basis.
Anybody else?
It's Pete. Can I just make a comment? Because I think this group is critical to keeping the push for the undergraduate education in ultrasound going. Basically what everyone else has just said, that, you know, with all of these projects that all of you have done and have done so well, it's going to be the rural use of this technology that is going to drive the further education. Now, whether it's actually at the undergraduate level or whether it's at the postgraduate level, it's this group or groups like this that are going to keep that pressure on. And, you know, demonstrating the utility in a number of different areas in a number of different ways is critical because, and as has been said, we're at the beginning of that curve, and the slope does increase, but it takes a long time at that, you know, beginning end. And it seems, you know, like we're going nowhere for a long time. And then all of a sudden it's happened. And I think this, you know, the development of the electives is a great example where we're going to have 2 this year. And Tracy, you and I talked about this. My idea of a success is having 1 student do 1 elective. I think we're going to reach that goal this year. And so then, you know, next year, will it be 4 students in 4 electives? You know, so I think it's I just want to put my 2 cents in where if I can continue to be a member of this group, it would be extremely valuable in the position that I'm in.
Okay, wonderful.
I guess the question then I think is, when do we meet again?
Well, yeah, I'm thinking also about, you know, if we were to have a bit of a strategy and, you know, to have somebody like with Jude's background in evaluation and implementation potentially as well, like, you know, she's using terms like PQI and like that. It's not, I don't feel comfortable developing a PQI or a QI framework for how to measure quality and how to design even a project in the first place. So, you know, potentially that could be like a second phase, is like, now we have this data and now we have some sense of what to do with it. Well, how do we ensure we're doing it? And what are the barriers to implementing it? You know, that's, I think maybe thinking ahead would be leveraging more external supports for figuring out how to come up with a plan for implementing things. So Jude, we might be talking again.
I would love to. You know, based on today's discussion, I see a real tripartite approach of this group. We've got, you know, lots about education and the need for continued advocacy around education. I think we've got lots between what Svetlana was saying and our data around policy and the need for policy interventions at a provincial level. That would really help with the diffusion of point of care ultrasound. And there's also, of course, the research evaluation framework. And within that, I would consider CQI and that kind of, I hesitate to use the term quality assurance, but more quality improvement. And again, doing that through a rural lens to make sure that it's peer-to-peer is what we heard and what the literature says is so important. With those 3 approaches, I mean, I think that that's a very strong mandate for this group to look at evaluation policy and education. And if we had that, you know, unless I'm missing something obvious, but if we had that as a mandate going forward, I think that would make this group very effective. And the value, well, not the value added, the importance of it is to make sure that, you know, I'm off at UBC doing a lot of research and, you know, talking to people, but not necessarily everybody. And what we don't want to do with such a small group of people interested in rural point of care ultrasound is have unproductive redundancy. What we want to do is be working to synergy, right, so we can build off each other. And I've just made a whole bunch of notes, Svetlana, of how our data sets intersect and what we could do with that. So I would really be sad if this form wasn't available, but would also like to optimize our time together. Like, do we have that mandate to look at policy, education, and research eval, or more?
Well, that's inspiring. So thanks for everybody's feedback. It really provides, for me at least, a bit of clarity